And I would like to introduce our speakers from Unislink today. James Muir is the Senior Vice President of Physician Services, as a highly respected growth leader and seasoned revenue cycle expert with 3 decades of experience transforming healthcare organizations. He has dedicated his career to simplifying complex business challenges and leveraging technology to deliver measurable results for his clients. Tennille Mile is Unislink's Director of Credentialing Services, bringing over 17 years of experience as a leading expert in provider enrollment and compliance. She is a master of streamlining credentialing workflows to reduce turnaround times, ease administrative burdens, and keep revenue cycles running smoothly to prevent payment denials and maximum reimbursement. Welcome, James and Tennille.
All right, wonderful. Well, thank you for the introduction. It's great to be with you all today. We really enjoy these opportunities to kind of share what we find exciting about credentialing. And my promise is that before we're done, you'll be excited by the possibilities too. And I'm excited to do this session with Tennille, right? She's a longtime friend and she's a longtime credentialing expert. She's been doing this for almost 20 years now. And that means we're going to just be able to draw on all of that experience that she has as we go through the content. So you're welcome to ask any questions that you want as we go, and we'll try to incorporate that if we can right at the time that you ask the question. If not, it's okay. We'll have a little time at the end and we can catch up on any questions that you may have had, but you're welcome to use the chat for any questions. So, but Tennille, thank you for being with us today. I know how busy you are, so we're grateful that you're here.
Of course, it's my pleasure, James. Thank you.
All right. Well, so here's what we're going to cover today. So we're going to spend a minute on the current industry trends and challenges when it comes to credentialing. We're going to talk about what we'll accomplish on this session together. We'll spend a minute on the need for credentialing and the implications of getting it wrong. We'll talk about the differences between credentialing, enrollment, and privileging, how those are different. And then we'll talk about the various different forms of credentialing that are out there. And then we're going to spend the rest of our time discussing, automation, how to avoid delays, credentialing best practices. And then finally, when we're done, we'll show you a way you can get some help. So hopefully that sounds like a good plan. Let's jump right in here. When I attend these kind of sessions, I always like to get some data or some metrics that are kind of hard to find. And so we wanted to give that for you, get that to you here sometime early in the presentation. So here are some facts and trends around credentialing that I think you'll find interesting, maybe even a little bit shocking. But the first is, and maybe this won't be a surprise, but the average credentialing process for a single provider takes between 90 and 120 days. Each individual provider application takes somewhere between 12 and 20 hours per payer to complete. And delays in credentialing actually create what we call an opportunity cost. That is because we can't see patients, right? So we can't generate revenue until the credentialing is done. And that opportunity cost averages between $2,000 and $3,000 per provider per day, depending on the specialty. And so that means that the annual losses due to credentialing delays can be very high. It can be as high as 60 to 100 grand a year per provider. So it's a pretty big deal. On the operational side, on average, each provider maintains 19 or so credentialing relationships. That's across the whole country. But I can just tell you from experience that in markets like LA and Orange County, it can be way higher. Because of all the IPAs that you guys have, we have one organization that we work with that has over 100 plans per provider, which is mind-blowing. Statistically, 85% of all credentialing applications have errors or some kind of missing information. And of course, that creates delays. And probably the most depressing, and I was going to ask Tennille about this earlier when I was talking to her, but probably the most depressing statistic is that a credentialing agent, the turnover rates are among the highest turnover rates in the entire healthcare industry, with average turnover in 2024 being an incredible 51%. And that's because credentialing is hard work. I don't know. So thoughts on the metrics, Tennille?
Oh, gosh, yes, lots of them. So it is extremely common for providers to be enrolled and require a maintained relationship with at least 19 major payers. And then when you calculate in all of the additional lines of businesses, networks, and supplemental plans, the provider's payer list can become quite extensive and usually ends up tripling the work that is required to maintain those enrollments effectively. Now, regarding the 85% statistic, James, related to the credentialing application errors and missing information causing those further delays. This almost seems to be the new tactic that the payers are hoping will allow them the reason to reject or deny the enrollment request. It can be from the simplest errors, such as abbreviations of names or practice locations. For example, if the provider's medical license has the provider's middle name listed, and then on the application it is abbreviated, then this can trigger a rejected application. The same for a practice location. If the W-9 or the IRS letter shows the word street for the physical location address, but on the application it's abbreviated as ST, this can also trigger a rejection. If current documents are not submitted with the application, this will absolutely result in a denial or rejection from the payer, even if the document was current when you submitted the enrollment request, such as a medical license, a DEA, or a certificate of insurance. If it is set to expire during the middle of the processing timeframe, then the expectation is that the updated document is sent to the payer for continued processing. As we know, these payers can take many months, as we see, to process an enrollment request. So the documentation that was originally sent for the initial submission may not be current by the time it actually crosses a credentialing representative's desk to review. Now, those turnover rates, I am disheartened to say that this is not a surprising figure to actually see. From the payer's end, this is one of the reasons that almost all payers have discontinued their dedicated provider representatives, which used to be in place for each and every payer to handle specific enrollment accounts. But due to the demand placed on the remaining team to ensure that all enrollments are completed and the workloads becoming larger and larger, it is becoming a less sought after position by far. The staff members that are in the positions for the right reasons to actually ensure providers are enrolled for proper reimbursement and for patients to be able to be scheduled and know their practitioner is actually in network with their insurance are not the ones that are working for the payers, because the network systems are designed to reject and deny enrollments over the slightest issues, and it becomes a heavy burden for an employee to have to constantly relay those decisions to the providers. It's much different now from just a decade or so ago, when the payers used to beg for the providers to join their networks and have the provider reps to help them achieve their active statuses. Now it's a true battle to get the payers to let you into their doors. But if you have dedicated, strong-minded, knowledgeable individuals or teams that are driven by integrity working towards the right goal, then it's definitely an achievable task. Just much more difficult than ever before, and becoming increasingly much more difficult with every passing day.
It's incredible. So let me ask you a selfish question before we continue
Sure.
here. Why? You would think that they would want to have providers to be able to service the patients that they have. Why are they? It seems like their goal is to keep you out rather than
It is their goal. Yes, very much. So they don't have to pay, right? They get all of those premium payments from their patients, but then they don't have to release it back to the providers that's providing the care that's truly needed by these patients. But
It's a
that
trap.
is absolutely the goal that they're aiming for these days.
Incredible. All right. Well, before we throw you all into a fit of depression here, let's just talk about what the session is all about. And the goal of the session is just to help you minimize lost revenue and all those headaches by giving you a practical, step-by-step approach to effective credentialing. So that's what we're going to do in this session together. And so let's just talk a little bit about why credentialing matters here, right? And probably everybody knows this because they may have experienced something with this, but credentialing is not a trivial task, right? In fact, it's a mission critical administrative task. It's required by law. And it has direct, often immediate impact on whether or not practices are going to get paid. I mean, it does do the other things that they claim, right? It ensures patient safety and health is part of your network management and promotes trust and confidence. But the real reason that credentialing is so important is because it's required by law and required for reimbursement. And if credentialing is not complete, at best, we don't get paid. And at worst, we might be breaking the law. So credentialing issues are still a leading reason why claims get denied. And so getting that nailed down not only protects your organization legally, but it's literally crucial to keeping revenue flowing. So I don't know, what do you want to add to that? What kinds of issues have you seen?
Oh, well, I've seen the best of the best, James, and I have seen the worst of the worst, unfortunately. Not to shed light on solely the negative here, but I think the two worst case scenarios I've seen in the last almost 20 years have been one, patients not being able to be scheduled for surgeries and procedures that were medically necessary due to their desired provider not being in network with their insurance. And two, providers that have dreamed of opening their own practice for years and finally making the leap to do so, having to close their doors due to the credentialing and enrollment process being continuously delayed. To know that credentialing can take 3 to 6 months or longer requires a lot of capital to sustain the dream of opening a practice. But when the payer's delays turn the time frame from 3 to 6 months into a 9 to 12 month processing time frame without any care or consideration of the ultimate goal, and the owner not being able to continue without the projected reimbursement for those extensive periods, it's just almost unbelievable that such an event could actually occur. And yet that's the reality for some practitioners who just wanted to offer more options in additional locations for our population.
Yeah, I've seen it. It's heartbreaking when I see a startup that have to close their doors just because they couldn't get
Mhm.
credentialed. Buddy, it's not
Absolutely.
one of those things you can just assume is going to happen and that it's an easy thing. All right, well, let's do a little bit of education here.
Yep.
So credentialing, enrollment, and privileging, all three different but interrelated processes in medical practice management. They all have a slightly different purpose, and and they all ensure compliance and patient safety. But credentialing is the process of verifying the provider's general qualifications, right? It includes training, licensure, certification, education, work history, that kind of stuff. And basically the goal here is that it ensures that the provider is meeting a minimum standard that's required, to practice medicine safely and effectively. Enrollment, on the other hand, is the process of adding a provider to some kind of a payer network. It might be commercial payers. It includes Medicare and Medicaid too. And that's so we can bill and so we can get paid for those services. And it's really the step that establishes the business relationship between the provider and the payers, right? And ultimately allows them to get paid for seeing their insured patients. And privileging, on the other hand, is the process of granting a provider authorization to perform some specific clinical procedure at a facility somewhere. And it defines the scope of practice, meaning what can they do, and the clinical responsibilities that the provider can have at that facility. So let's see if I can summarize that in a single sentence. So credentialing is about verifying who the provider is and that they're qualified.
Mhm.
Enrollment is about getting them paid, right? And privileging is about clarifying exactly what kind of care they're allowed to deliver at a facility. So, and Tennille, I know you onboard people all the time on your team. When
Yes.
you're onboarding and credentialing new employees, are there any educational issues around these three things that get confusing or that people sometimes get hung up on, or can you
Yes.
elaborate a little bit?
Absolutely. I mean, as these three different but interrelated terms are almost becoming a bit interchangeable when you're speaking with new employees, new clients, new providers. And the term credentialing somehow has become the universally used phrase to mean all of these things, but they are very distinct and different tasks. So quite often a bit of teaching and or information sharing sessions must be performed in order to know what it is that the provider needs exactly and which term truly covers that task. So we do have to do a lot of um, helpful tips and training processes in that.
And that's with our people. What about clients? Do clients sometimes occasionally confuse one with the other? They assume that
100%.
when they talk about credentialing, they're really talking about privileging or something like that.
Yes, absolutely. It's interchanged so often, so frequent that credentialing is that universal term that they're using to cover all of this. And when they're coming to us looking for credentialing and we are focusing on provider enrollment, we really have to clarify what the true need is at that point so we know how to best offer it.
Gotcha. All right. Thank you for that. All right. But this slide's kind of a big picture look at the entire credentialing process. Don't get too hung up on this. We're going to give you a simpler one in a minute here. But it all kind of begins with this sort of pre-application prep. And that's just making sure that all the required information and documents are collected and ready to go. And then we're going to submit an application. And once that is submitted, the real work starts, right? There's screening that goes on, there's background checks, there's verification of all the qualifications, primary source, all that kind of stuff that happens. Next, after that, typically there's a credentialing committee review. Experts are going to review the application and validate the results for any concerns or red flags. And of course, if the provider meets all the requirements, then they move forward with approval and privileging, and that gives them a green light to start seeing patients and bill the payers. But that doesn't end. In fact, it never ends because credentialing is cyclical, right? So you're going to still have to monitor, your and have regular recredentialing, and that's going to ensure that every provider on the roster continues to meet those standards and always remains in good standing, right? And so, like I said, this is kind of a macro model. Most of you on this call will probably not be dealing with this model, so we're going to show you a simpler model here in just a second. And with that model, we'll talk more about the individual stages that are part of this in some upcoming slides, and we'll talk about some actions and practices you can do. But Tennille, I'm going to, rather than maybe comment on this one, let's wait till we get to the slide I think that's most relevant to them. And then maybe if you want to, you can contrast sort of the mega model versus the more specific one that they're working with.
Sure.
But a lot of the models kind of break depending on who's finding all the information about the provider. So this slide is kind of just showing some of the key categories of documentation that are often required, typically to credential healthcare providers. And there's really a broad range of documents here. I mean, you see stuff on personal information, professional licenses, insurance, education, that kind of stuff. And maybe without going to each one, the main takeaway here is that credentialing demands really thorough, complete, and up-to-date documentation for each of your providers. And so collecting and maintaining those documents in an accurate way is essential if you want to have a smooth credentialing process that doesn't have delays in it. It's basically the foundational step that supports the overall goal, of getting the provider credentialed. So, but maybe you could, Tennille, give us a little color here. I mean, you've seen everything there is to see. What types of things when it comes to provider documentation have you seen? What kind of things do people get tripped up on? That kind of stuff.
Sure. So when it comes to documentation, you must have it all. Everything listed here, if it exists, it needs to be shared with the identified individual responsible for your credentialing, provider enrollments, and privileges. From a provider enrollment standpoint, every payer requires a bit of a mix for which documents they wish to see. Some want the medical license wallet card. Others are okay with the online verification printout. So it is just a best practice to ensure that there is a complete and maintained record of all documents at all times. There will often be payer requests needing an updated document to be put on file. And the last thing anyone wants to do is to bother a physician to have to obtain it. This isn't, especially if it's not already on file. And some of the payers may only give you a 24-hour window to provide it. So there definitely needs to be a streamlined process in place to track expirable documentation to ensure that the provider's file is always in a current and active status for immediate use. Because as you know, James, these payers can take 6 months or longer to process their requests in those applications. However, they can give you a deadline of 24 hours for an updated medical license. And it's wild.
What irony. Well, all right, so let's kind of get closer to that simpler model here that we're going to be dealing with that I think this group will be dealing with on a daily basis. So this slide is basically summarizing the 3 most common approaches to provider credentialing, payer enrollment, and then how they expect affect both the speed and the complexity of onboarding. And so first you kind of got standard credentialing, and that's where the health plan or the payer is verifying each of the provider's qualifications. And Tino just commented that they're kind of doing that less now, but they're doing all of that. It does give the payer full control, but it also tends to be the slowest of all the models. So very few people do it this way anymore. And it seems like the payers themselves are trying to get out of that. Next is delegated credentialing, and that allows a provider group or a credentialing verification organization, sometimes we call them CVOs, to perform credentialing on behalf of the payer, right, or a roster of providers. And as long as that CVO, meets the payer standards, and they undergo periodic audits, they can onboard entire provider panels much more efficiently. But that approach is generally best suited for really large medical groups, hospitals, networks, that kind of stuff. Okay. And then finally, there's the one that really probably everybody on this call is going to relate to, and that is the direct provider enrollment. The provider or the practice applies separately to each payer or insurance network for both the enrollment and the credentialing. Each payer processes and approves the enrollments individually. And this approach is really the most common for new practices, solo groups, anybody joining a fresh network. It's also the one that is most outsourced of all the ones on this list. So the takeaway here is just that while delegated credentialing and direct provider enrollment are sometimes outsourced, they both are much, much faster. But it does require that you have good accuracy in all of your documents and good compliance there. So whichever method, it's pretty much always the responsibility of the practice or the provider to verify and maintain accurate source information, right? Since it's those errors and omissions that end up impacting the participation of whether or not they're going to approve it or not. So, all right, there's a ton on this slide. What do you want to add to this little contrasting of models, Tennille?
Just a bit. So these are the three most common approaches to credentialing and payer enrollments, but are all very unique depending on the practice's needs. My main level of expertise is regarding the direct provider enrollment, and that's where I'll be speaking from that perspective for the majority of today's presentation. So I'm excited to talk about all of that and dive into that in full depth.
Okay, let's look at the model then. So this is the simpler model we talked to you about, and this is the one that pretty much everybody on this call is going to be doing. So this details sort of the direct provider enrollment process as experienced sort of by the practice, right? So we have our own models here at Unislink, and we want to give you one that you could relate to in your practice if you're doing the credentialing, right? So, but in this model, the practice is responsible for orchestrating every step, right? Either by managing the work in-house or occasionally, again, groups will outsource this to a third party. But first, the credentialing information, you have to gather it and get it all prepared. And that often means chasing down licenses, board certifications, malpractice insurance, right? And that type of stuff from the doctors. And then, there may be, if you're using an outsourced method, you'll have to pull all that together and then supply it to them first before they can even get started. Second, the submissions are then prepared and then sent to each payer. And then if it makes sense, that this is also where you might start the hospital privileging steps. What happens next is sort of a blend of, persistence and organization. The practice, you have to actively follow up with each payer, checking on the enrollment status and responding quickly, like Tennille said, that you might only have 24 hours to respond, and then ensuring that there's no application that falls through the cracks somehow. And then next, you've got communication status and updates. And whether you're doing it internally or using a service, you really have to keep your providers and leadership informed because they are delaying possibly scheduling patients with providers until the credentialing is in place, right? Even when enrollment's complete, of course, it doesn't end there, and that's because the process is ongoing. You have to maintain that data. You have to track renewals, and then make sure that the recredentialing tasks are happening so you don't have any lapses. And then, throughout the whole process, of course, you're going to want to use best practices. You're going to want to document meticulously and a bunch of other stuff that we're going to talk about here. But again, regardless of whether the work's being done by you or some kind of a third party, this process is essentially the front line for getting your doctors all enrolled effectively and keeping the practice operations running. So again, there's a ton to unpack here, and you can drill down on any particular step that you think people trip up on or any of that. But what would you highlight here on this simpler model?
Gosh, James, I mean, this is what I've lived and breathed for almost 2 decades, right? So when you see it, and you see the direct provider enrollment process in a condensed 7-step, screen, it seems fairly simple. But, yeah. Yes, and I could talk all day regarding this, but just to note that each of these 7 steps has approximately 20 to 30 sub-steps within each of them, where having a dedicated specialized individual in place to maintain this workflow is key. Without having the expertise to know what all is involved in each of these steps and sub-steps that you're not seeing that are required can cause exponential delays in the enrollment process and can happen before the payers are even becoming involved in the whole process. I think something worth mentioning regarding step 5, the payer enrollment follow-up, would be to ensure that once an application is submitted to the payer, that an initial confirmation call is placed within the first 2 weeks post-submission. This allows the payer time to log the receipt of the application, because if you call too soon, you may be falsely informed that the application wasn't received and instructed to resubmit. However, in doing so, I have seen payers who have rejected enrollment requests due to multiple applications being on file, stating that they're unsure which ones to process. Just when I think I've seen it all, here comes a new denial or rejection reason in my inbox. So the continuous follow-up on an every 2-week basis at minimum is key. This can be extremely tasking as many payers' hold times are more than 40 minutes long. Jumping through the voice command options can lead you in a circle, or never getting to speak to a live representative can become extremely frustrating. But it's an essential piece of the puzzle because it gives you leverage that you have a date and time stamped record that a call was placed and that you were informed that the application had been received and that nothing additional was needed at that time. This drastically improves your dispute cases that often must be filed when all of a sudden a payer rejects the application or tries to say after 6 months into the process that there isn't an application on file and that you must restart the enrollment process. So, like I said, I could go on and on here for days, but that's probably the key one to mention is the consistent, persistent follow-up.
Okay, so maybe we can talk about some mechanisms that you use or that you can recommend groups use when we get to the technology piece of this for making sure you don't miss any of those. But anyway, that's very interesting. I'm glad we made that little particular part of the slide red.
Yes.
All right, so this slide is summarizing some of the more important strategies to try to make it smooth and efficient. And so by putting some structure into your credentialing workflows, maybe leveraging some tools that hopefully Tanil will give us some insight on, you can reduce the number of errors and the delays that you're getting and stay ahead of any requirements that you've got. Adopting the best practices not only protects you from risk, but of course, make sure that your providers are always ready to deliver care without any interruptions. So ultimately, in a phrase, maybe good, I could say good credentialing is sort of the foundation of good rev cycle. So again, there's a lot to unpack on here. You don't have to go through everything, but what would you like to highlight here in terms of best practices? And if you want to add one that didn't make the list, I would love to hear it.
Sure. So all of this is so key essential to the credentialing process. The centralized documentation housing is a must. It is the only efficient way to maintain and manage documents as well as enrollment records for the providers. I cannot recommend this enough. Beginning the process early, I can't stress the importance of this one enough either. As we have discussed, the lengthy enrollment timelines are one of the best ways, or the initial fast speed enrollment process is one of the best ways to get enrolled timely. And the best way to do it is to start it early. There are some payers that will not let you begin the process more than 30 to 60 days in advance, such as Medicare. However, it is true that the early bird gets the worm. So the earlier you can get the application in the door of the payer, the sooner that you'll be able to get processed, the higher up on the stack you'll get. So they do truly work the applications in the order in which they are received. So if 500 providers are ahead of you in line, then you can imagine how long the processing time frame may be. So to avoid common errors by ensuring the individual is completing the application truly is a specialized person in their field and understands the difference between, let's say, a type 1 and a type 2 MPI number, they have to have a high level of built-in compliance to ensure that they don't accidentally fill in a box that says, for example, county with the answer of United States of America because they thought it said country. I've seen this. This can be the reason for a rejection. And even the simplest errors or mistakes can obviously create a delay. So monitoring progress and follow-up, making sure to notate every submission method, when and how it was sent, obtain call reference numbers for every call that is made to the payers for all of the needed outreaches. Consistently following up is truly required to help prevent any unexpected kickbacks. Now, staying up to date on the payer, state, federal regulations is also super important. payers are notorious for updating forms and required documents needed for enrollments. So during the routine discovery calls to ensure the team has the appropriate forms and applications and are submitting to the proper place for processing is a key step that can also cause a delay or a great deal of stress, because there's nothing worse than waiting 6 months to receive a response from a payer that is informing you that they actually updated their forms 1 week prior to your submission and that you didn't submit the proper form for processing, and now you must restart the process over. So once again, another slide here, James, that I could go on and on about, but I think those are the key highlights.
Okay, well, maybe you can give us some ideas about tracking and managing all that stuff here from a software perspective. So in this section, we're going to talk a little bit about automation. And what this slide is doing is it's trying to highlight some of the technology-driven solutions that you can use to make your credentialing process more efficient. And there are software platforms for this, and I'll ask you some questions in a second. I'm really interested in your input on that, Tennille. There are softwares out there that can automate virtually every step, right? From collecting and validating documents to credentialing to tracking expiration dates and all that stuff. And so I guess the question I'm going to ask you here in a second is, but if my practice is pretty small, is it really worth investing in software to do that function, or can I do it with spreadsheets? So you can cognate on that. But obviously the goal of using some software is to help reduce the time it takes and the administrative burden it takes to do the credentialing. So another feature that I have seen in some system is schedule blocking, so that uncredentialed providers can't be scheduled, right? And see patients that they're not already credentialed for. My personal opinion, there are cheap workarounds for that if your software doesn't do that, but it is a source of denials that we see on the RevCycle side is, they saw a patient that they weren't credentialed for, and then that's, you just gave away services for free when that happens. So, all these tools help. So again, there's a lot here. Where do you think that practice can get the most bang for their buck when it comes to using software and automation to try to manage all that?
For large practices and companies, I'm definitely going to have to say both. Now, for smaller practices, if we're talking less than maybe 10 providers, I would say software is going to be in their best interest. And depending on the specific software that they choose, there is a great deal of automation processes that are typically already built inside the software that can drastically reduce the employees' hours that are spent on credentialing and provider enrollments. I've been on both sides of the fence regarding using software, not using software, and just simply as an expense saver, especially for smaller practices. But in my experience, it's almost a no-brainer that if it is within the budget, to definitely commit to a software agreement. If truly, it truly will save you time in the long run. So can an experienced individual team work off of Excel spreadsheets and OneNote documents? Absolutely. Can it be effective? Sure. Is it the most efficient way? Hands down, it's not. What you think could be logged in one spreadsheet or easily turns into 10 or one massive spreadsheet with over 100 columns of data. The reporting capabilities are almost non-existent within the use of the software programs, and to ensure everything is date and time stamped, as you will find to be a requirement when battling these payers, not to mention the audit trail that you'll always and forever want and need, it's very evident that the software programs are definitely the way to go, James.
Okay, good answer on that. Real quick, not exactly contextual, but I think we'll add. So a group has asked, I know you have to have an address, but what about an active or signed lease? If you have the address, but you haven't signed your lease yet, do you need to have that in order to start the credentialing process, or is it just sufficient to have the address?
So both. The payers are going to require that signed lease to be able to begin the enrollment process. Address is key, but they're going to want to see that agreement that's in place, that you are leasing that space for them to be able to pursue and process the applications.
Okay, would we delay the application then until the lease is signed in the best case, or can you sort of start with the address and then add the lease later?
Depends on the payer, James. So if you know your payers well enough, some of them you can go ahead and squeak those applications in their doors and then provide that lease agreement at a later date, because we know they're not processing the application within week 1. But however, some large payers do not want additional submissions. They want everything in one packet, one file to be submitted at once. So everything needs to be included in that initial submission. Otherwise, if you send one piece of it and they're reviewing it, they're seeing that the lease agreement's missing. So they're going to reject it, deny it, kick it out. And you've sent it in 2 weeks later, it's in their inbox, but they've not gotten down to it because of the stack in between the date that you initially submitted the information versus the follow-up information. So it definitely depends on the payers. And for those large commercial payers, your best bet is to make sure that you have everything and send it all at once.
Okay, I was just going to say, it sounds like it's best to have both together. All right, well, good question for whoever submitted that. Thank you so much. And then let's talk about avoiding delays here. And this is going to actually relate to some stuff we've already talked about. But what this slide's doing is kind of talking about the core strategies, which you are going to recognize. Some of the items on here are familiar to the ones that we just saw a second ago in terms of best practice strategies. I think the main message here is start early, right? Is the sooner the better when it comes to the credentialing process, as payers have slower, really unpredictable approval cycles. Stay organized, centralize your records, use detailed checklists, leverage automation where you can. And then regular monitoring, clear communication, literally one of the steps that was in the model that we showed a second ago. And that's because you're trying to make sure that progress doesn't stall due to some missing information or some unreported change that's happened on the payer side. And then, like you mentioned a minute ago, it was the second to the last one on the other list, which is keeping current with payer policies. So we need to schedule routine audits and just make sure that nothing falls through the cracks, right? So, in terms of the things that usually you see, like I realize that almost everything can cause a delay. It seems like, but what are what are the top 2 or 3 things that you see that are the main culprits for credentialing delays?
Absolutely. So I do believe that we've touched on the majority of these, but that's going to be 1, start early. 2, be thorough with your outreach to the payers and with the application completions. And then 3, follow up routinely. That's it in a nutshell.
Okay, great, concise answer here. All right, well, let's talk about recredentialing then. Recredentialing, that's that sort of essential periodic process of re-verifying and updating the provider's credentials and ensuring that you've got ongoing compliance, right? And unlike initial credentialing, which happens only one time, recredentialing happens, I don't know, maybe every 2 or 3 years, depends on the payer. Recredentialing does repeat, I think, a lot of the verification steps that are in initial credentialing, but you again update all of that documentation. And so maybe just give us sort of your high level thoughts on recredentialing and the whole recredentialing process.
Sure. So key tip here is do not rely on the payer to communicate to the provider that they are coming due for recredentialing. Tracking this from the date of approval is key to avoid a missed revalidation due date. Also, like with initial enrollment, start the revalidations as soon as the notifications are received, or at least in plenty of time for the payer to process the request. It is worth mentioning here that there are some payers, specifically state Medicaids, that will send out a notification 60 days in advance, but the processing time frame is 6 months. And if the revalidation is not received and approved, there's the key, approved, then they will stop payments from being sent based on the revalidation due date. We are seeing this more and more across many states that the revals must not only be submitted, but must be approved in order to continue to submit the claims to the payer for reimbursements. We're also seeing more and more payers that are not willing to backdate effective dates of coverage if you miss a revalidation due date for any reason. And also, these are 2 additional universally interchanged terms, James. So recredentialing and revalidation are often interchangeably used by the payers, just to note.
Okay. So let me just drill down on that just a little bit. So when would you recommend that we start the recredentialing process then, based on so I created a tickler, it's come up, it's time to consider the recredentialing process. Should I be doing that 6 months in advance? Give us some guidance.
Also depends on the payer. So we kind of keep track and keep record through all those discovery calls and processes of which payers at which state level, what their typical timeframes and processing timeframes look like. So if we know a specific payer is going to take 6 months because that is their timeframe, their turnaround time, then we know we need to send that in prior to 6 months. If the typical processing timeframe is 30 days, then we know we have some leniency and we'll do a 60-day, ahead of time. But it
Okay.
just depends on the payer and the state.
How do I know though? How do I know which one is which for each payer?
It's going to be an outreach to those payers, which also requires a lot of sitting on the phone and waiting for someone to answer your call. Now, this also is ever changing in the payers, right? So today you could call and they could tell you, well, our typical turnaround time is 60 to 90 days. And then you could call next week and they've had an influx of 1,000 applications come in their door. Now their turnaround time has greatly lengthened and you are, at their mercy, obviously. So definitely consistent outreaches to payers to stay in the know with what their turnaround times are, what their processing looks like. Do they handle revalidations ahead of initial enrollments? Typically, that's not the case. Typically, the payers will handle initial enrollments first and do the recredentialing later. It's questions that you have to ask directly to the payers to find out. If you handle the initial enrollments prior to recredentialing, then when you get to recredentialing, applications, are you going to grant the original effective dates? Or is there a potential for any lapse? Is there a potential for claim reimbursements being stopped because of the due date not being met within the payer's parameters? So definitely tons of outreach to the payers is what would be required.
Okay. So is it ever a mistake to try to start the process too early?
No, thankfully, unlike the initial enrollments, there isn't such burdens by the payers. So if you want to do a 6 month in advance, by all means, get it in their door. They may go ahead and slide it off to the side or tell you, hey, you're not due for another 3 months. And then we'll process you properly from there. So there isn't any hindrances to go ahead and get those in the door early. Now,
Okay.
once you're approved and you're approved for 2 to 3, or even some states and some payers allow 5 years for recredentialing and revalidations, they obviously are not going to allow you to begin that process, at the 4 year mark or the 3 year mark. So kind of just have to gauge it from there.
Okay. So one last question here. Sorry to spend so much time on this slide. Um, what scenarios happen that force us to have to repeat initial credentialing? What can happen that would cause us to, instead of just recredential, but have to start the whole process all over again? What should we be looking out for?
That's those missed revalidation requests. So if you have a revalidation that was due and you are none the wiser that that was up and due, and then all of a sudden you're not receiving payments, it's because you've been dropped off of the network's panel. They have termed you as a provider. You are now out of network and you must restart the enrollment process, which is going through the initial credentialing event.
Yeah, I had a client in the Midwest that actually that happened to it, and it was catastrophic because
Yes.
they stopped getting payments from the payer for several months while they tried to get initially recredentialed for everything. So
Hmm.
definitely
Yes,
bad scenario. Okay, so thanks for indulging me on that.
of
Um,
course.
all right, so we may have already covered many of the things on this slide, so I'll let you just pick and choose. But what this slide's trying to do is, talk about the most common pitfalls when it comes to recredentialing. And so maybe I already jumped the gun, but maybe you could just peruse over this and then, speak to whatever you think is most relevant here on this list that we've missed.
I mean, obviously, all of it very, very relevant. But I think the biggest mistake that I've seen is that the providers are relying on the payers to inform them of the need, but yet never receive the notices, as well as providers submitting enrollment requests prior to the deadline date. So, however, even if you send it early, it may not be timely enough to allow for the payer's processing timeframe. So I think that's the two biggest issues is the providers are waiting for the payer to send them the notification, and the notification is going to maybe a previous credentialing vendor that was handling all of that for them when they did the initial enrollments, and that's the information that's still in file. So they never receive the notification, so they have no idea that it's even due. So that's, number one. And then the second one is if they do know that they're up for revalidations, they send it in thinking that all will be well. However, they send it in before the due date, but not in enough time to actually have it processed by the payer.
Okay, back to our start early theme before.
Yeah.
What about that multi-state? I bump into clients that are exploring doing telehealth in many, many states. And I think they greatly underestimate the scope of the work involved in getting credentialed in all of these different states. So any thoughts on that particular one?
Oh, yes. So multi-state credentialing is that in a nutshell. It's per state base. There are a handful of payers, and I'm talking very, very limited, that will allow you to do multiple states for your enrollment purposes. So pretty much every payer is state specific, and you have to go through that specific enrollment for that specific provider in that specific state. So if you're enrolled in multiple states, then it's going to be multiple states that you need to be revalidated within as well. So initial credentialing for all of those states, and then the revalidation process in all of those states as well. So it definitely is very tasking, very time consuming. And of course, you have to follow all of those state specific guidelines and rules.
It seems like if you didn't have a ton of volume coming in from a particular state, it might not even be worth the energy to do all that credentialing. Would you agree with that?
We see that quite often, yes, where they initially get enrolled and don't see the need to continue those enrollments and just let them kind of fizzle out naturally. We do see that often.
Okay. All right. So let's kind of pull all that together into some actionable strategies here to help everybody keep about, ahead of the curve. First, automated systems. So you've recommended that they get some software to help them, and then keep a centralized digital repository as sort of a foundational, or it's just too big to track any other way. And then you mentioned earlier starting the process early. What about using detailed and customized checklists to help you go through that? Maybe for the state requirements or something. Do you have any thoughts on that?
Absolutely. And there's a lot of software programs that have that checks and balance, in place. It's a feature that they have where there is a check off box. There is a tracking that, essentially takes you from start to finish to know where you're at in that process, as well as upcoming revalidation due dates, et cetera, et cetera. So software is the way to go. If you are stuck in the Excel spreadsheet world, due to, financial reasons, it's okay. You can also create your check boxes down through there so that you know that everything is being completed, but having the check mark system is essential. 100% recommended.
Okay, well, we haven't talked about accountability yet. Well, maybe you have. You suggested you have some person whose job is that. But do you want to just talk about that just briefly to make sure that everybody knows whose job it is to do this work? Because it seems sometimes it gets dropped when shared responsibility is seen, or when no one's really said whose responsible it is.
Definitely. So, depending on the size of the practice, you could have one dedicated individual that's handling it start to finish, from the onboarding to the initial enrollments to the follow-ups to the revalidation request, CAQH reattestations, et cetera, et cetera. The list goes on, right, up the 7-step process. Or you could have multiple individuals that's handling this, and you need a streamlined handoff process between each of those individuals. But bottom line is you have to have specialized candidates in that field. You have to have someone that is truly dedicating their day for the right reasons. You don't want someone that wants a pat on the back at the end of the day because they did their essential job. You want somebody that is self-gratified from the process, so that when they are completed and they get the approval and they share the approval information, that no appreciation or thanks is even needed. If it's received, great, but we are in a world of a very thankless position in the credentialing and enrollment world. So we're used to it. You can go from hero to zero really fast. If you get those approvals, you're amazing. If you get rejections, what are you doing? What's going on? You're to blame. So you definitely need someone that's thick-skinned, but that specializes in this field. Everyone as a patient wants to seek a specialist and pay higher, copays to see them because they are specialized in the field that they're needing. And that's the same for credentialing. If you find someone that is specialized in this field, you're going to obviously get what you're paying for because you want that specialized attention, to know all of the attention to details, all of those payer requirements, to be able to handle it start to finish, and to get you to the finish line, which is to have approvals and to maintain that active status with all the payers.
All right. Well, let's see. I want to keep us on time here. So let's
Yes.
go through our home stretch here. So let's talk about CAQH for a second.
Mhm.
This is the Council for Affordable Quality Healthcare. And it's essentially the primary industry hub for provider data and commercial credentialing. It's a nonprofit organization. They operate the CAQH provider portal. And it's just a centralized place where you can put, input and maintain all of your credentialing information. That's beneficial for practices. Talk a little bit about how practices can leverage it, what makes it useful, how to get the most out of it, that sort of thing.
Sure. So CAQH is a requirement for all providers and should be accurate and reattested every 120 days. Although once a quarter is actually recommended. So I highly recommend every 90 days. You can designate an individual or a team to perform the reattestations on the provider's behalf. This information is often used by the payers to confirm information and sometimes is the sole use for revalidations with the plans. So it must be maintained, updated, valid, and current at all times, James.
Okay, so no ifs, ands, or buts. You're going to have to do it no matter what.
Absolutely.
Is there any nuance to using the portal and using it that would be beneficial for any of the folks on this particular call, you think?
Just making sure that it is updated and maintained. I don't know that they will see the benefits of all of that other than reaping the reward of having it maintained and updated on their behalf so that the payers can continue with those processings of enrollments.
All right. So the reward is smoother credentialing and re-credentialing, right?
That's right.
Okay. So now, this slide again is sort of some important strategy for getting the most out of CAQH. I think based on what you just said, I'll just leave it here as a reference guide for us. And then let's use the rest of the time that we have to answer any questions that the group has. So if you have a question you'd like to add to the chat, this is your last chance to do that. We're going to let Tennille, use her decades of experience and give us any real world examples or tips that we haven't already touched on, and then we'll summarize and wrap up. But I'm looking here. Now, someone asked this about CAQH. Are we seeing a large uptake in payers using CAQH for the recredentialing process? What would you say to that?
100% yes. And I can't wait for the day when they all do, right? When every payer has to go through CAQH for those revalidations. Right now, not the case, but there is a significant increase from just a handful of years ago when some of the payers were starting to dabble in that. Now we are seeing a definite uptick in that.
Okay, Marie is asking again about the lease here. She says, what if I have a lease signed, but it has a start date in a few months from now? Would it need to be active now actually in order to use it for credentialing purposes, or would the signed lease be okay knowing that it will be in place at the time that she's going to see patients?
Yes. So a future dated lease agreement, for as long as you're not requesting the payer to do an approval for you prior to that lease date, effective date, then you're good. So if you have a lease agreement that is effective October the 1st, obviously I would not suggest only submitting those enrollments now. But if you did, then they wouldn't do an approval as long as you're requesting a start date as the same as the effective date of the lease. So when you're submitting those applications to the payers, you can specifically request a start date for the provider or for the practice. So you would 100% be okay to go ahead and submit that with a future lease date.
Okay, well, that was about as much time as we have. So if you have any last thoughts here, tips that we missed, this would be your last chance to Neil to offer anything up. Is there anything you want to add to what we have covered so far?
Oh gosh, James, I mean, I could hold us hostage forever here, right? So I won't do that to you, I promise. I just live and breathe it. I love, credentialing in the world of provider enrollment so much. It is literally outside of my three children's my favorite subject to discuss. So I'm so grateful for the opportunity to join today's call and to provide as many tips and tricks as I could in a short time frame.
Yeah, we're super grateful to have you on. So this is a wrap up of, some kind of the most important takeaways. I think we've talked all about these. Your credentialing is not an option. You start early, and then use some automation if you can to help you with that, and then be disciplined in your approach. And then I think some groups, I can imagine that it's a little daunting. I'll bet you if anybody is a startup on this call that they're probably feeling a little overwhelmed at the moment here. But if any of you would like some help, there is a way, thanks to our CMA, Riverside County Medical Association, that you can get some help from us for free. And we know how challenging it can be to start down this road alone. So if you'd like some help, we can do a revenue cycle assessment for you, and we can help you, and we can do that on our CMA's dime. So if you'd like that, then just tap this QR code that you see on the screen here, or you can use one of the URLs below, or as was mentioned at the very beginning, they're going to send you a URL for this as well if you'd like. So there's no charge for it. It's just our way of supporting our CMA. So with that, Tennille, thank you so much. RCMA, thank you so much. It was great to be with you all today. I think this will be recorded, and you all get the examples of the slides. Someone asked that question, as well as the recording. So thank you so much. It was great to be with you today.
Yeah, thank you
Thanks,
so
everyone.
much, James and Tennille. We really appreciate being here